welcome to the Georgia Heart Ground Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers have been mitigated. If you have a question for the presenter, please wait until the Q&A segment. And if you're viewing online, please feel free to place your questions in the Q&A section, and we will get to that towards the end of the presentation. I'll now invite Dr. Ahmed, our Chief Cardiology Officer, to give the introduction of our speaker today. Thank you.
Just wanted to take a minute to introduce myself. I'm new here, Murtaza Ahmed. I'm the Chief Cardiology Officer for Georgia Heart Institute, and just wanted to express, the support of the institution, GHI, the system as a whole, for this educational program. Really glad to see that we have a program like this, and GHI, I think, is a really impressive cardiovascular institute. And as we work to improve and increase our presence, our awareness, reputation, I think looking forward to continue to support the Grand Round series. We're fortunate to have a lot of really excellent internal physicians and speakers, and we'll complement that with, I think, some external thought leaders from around the country as well in the coming months. So looking forward to having all of you here in the coming months as well. It's a pleasure to introduce Dr. Murtaza Sundhu. He is one of our electrophysiologists. We're fortunate to have him join us a few months ago. He came to us via Pakistan originally and from the Cleveland Clinic, and most recently completed his EP fellowship at the University of Kansas. He has an interest in complex ablations, VT, PVCs, as well as atrial fibrillation. He brings a really good skill set, something that I think is really beneficial for our community and our program. AFib, one of the most common diseases in cardiology and medicine as a whole in this population. And so really excited to hear an update. I know there's been a lot of stuff both at HRS and ACC in terms of updates and guideline changes. So thank you for doing this, Murtaza. We're all excited to get the update. And thank you all for joining.
Thank you, Dr. Aghalam and Dr. Ahmed, for the introduction. Like they said, I'm Murtaza. I'm one of the electrophysiologists here, and I'm going to be talking about the atrial fibrillation management. This is basically an update with the newer guidelines that came out in 2023, which were, it was decided to put out these new guidelines because all the management that we have known about atrial fibrillation has been changing dramatically over the last 10 years with all the new trials that have been coming out, and it has led to the changes in the way we approach atrial fibrillation, and hence these new guidelines are the cornerstone for management of atrial fibrillation going forward. I don't have any disclosures. My learning objectives are very simple: learn about the pathophysiology, the pillars of the treatment, and the indications for catheter ablation, all focused from the 2023 guideline updates. And we're going to go through in a relative sequence. So anytime I see a patient with atrial fibrillation, the first thing I think about is, when did they actually have atrial fibrillation to begin with? And this is one of the papers that was published in British Medical Journal a long time ago, actually, in 2011. And anytime AFib is first diagnosed, it's because they have a long episode of atrial fibrillation, but that does not mean that was the first episode of atrial fibrillation that they ever had. Typically, patients have had multiple episodes, and these are the symptoms that patients have prior to being diagnosed with the episode of diagnosed episode of atrial fibrillation. And then patients typically have what's called paroxysmal atrial fibrillation, which means the atrial fibrillation comes and goes by itself, and the light purple meaning normal rhythm, dark purple meaning atrial fibrillation, and this is time on the horizontal axis. And as time goes by, the episodes of atrial fibrillation keep on becoming longer to the point that it actually becomes persistent, and it would not go away till something is done, which is cardioversion or shock or any management. And then AFib will come back. Once you have AFib, you have AFib. It's not going anywhere. However, we can try and maintain normal rhythm in the midst of these episodes, and that is the goal and the cornerstone of the management of atrial fibrillation and rhythm control, to extend these times in normal rhythm. Despite whatever we do, or if we do nothing, patients will eventually become permanent atrial fibrillation. What that means is even the management, which is rhythm control, will not work anymore. And the way that happens is that initially there is atrial remodeling that starts. And as time goes by on the horizontal axis and the patient starts having atrial fibrillation, like this dark purple here, they initially have paroxysmal, and the remodeling keeps on getting worse to the point when it becomes persistent, and then it essentially is a substrate for AFib and not sinus rhythm at that point anymore. When we say these remodeling and triggers, what does that mean? That means that as we have paroxysmal atrial fibrillation and going over towards persistent and then permanent, the triggers for atrial fibrillation initially, or the modulating factors, are atrial extra beats or atrial premature beats, tachycardias, bradycardias, or all the other risk factors that we're going to talk about. These are the triggers or initiation, and these are the reasons for the paroxysmal atrial fibrillation. However, when patient switches over to persistent, because this is where the line goes down to switching over to more substrate for the maintenance of atrial fibrillation. So as time goes by, the substrate gets worse, and hence management of atrial fibrillation gets worse if we do not manage it upfront or early on in the disease course. Where are these triggers that we keep talking about? And this was figured out by Dr. Hesegara. This is like the landmark studies in the EP world, published in around 90s. What he figured out was that this is like a left pulmonary vein angiogram. He has catheters within the pulmonary vein, and these are the intracardiac EGMs, or electrograms as we call them, and this is the surface ECG. So what he saw, that even before we see a PAC, a significant time before that, there is a signal within the pulmonary vein. What that means is these triggers, the PACs, the extra beats that are triggering an atrial fibrillation episode, are actually originating within the pulmonary vein and then exiting at the end of the pulmonary vein into the left atrium and then triggering an episode of atrial fibrillation. This is how we figured out how the atrial fibrillation starts, where the triggers are, and then eventually what can we do about it going forward. In his study, he found that most of the triggers were actually in the pulmonary veins, essentially all of them. There are very few on the right side, and these are very like spontaneous or random, but they're no pattern to them. The only pattern is that the pulmonary veins are very consistently involved in the pathogenesis of atrial fibrillation. So what ends up happening with this is the simple cartoon you will see on the internet, that these APCs or PACs or extra beats come from the pulmonary veins, come over into the heart. This is what simply everybody knows as the R on T phenomena. Same thing happens in the atrium as well, that the PAC comes into the atrium at a vulnerable time and causes fibrillation in the atrium, and then that spreads. Once you have atrial fibrillation, whether there is more current flowing from the pulmonary veins or not, it does not matter, and it will just perpetuate on its own. So now going to a little bit more about why does that happen. Everybody is, wrong button, at risk of atrial fibrillation, and this is from the modifiable factors like obesity, lack of fitness, hypertension, sleep, alcohol, diabetes, and then there are some non-modifiable factors, and then they go into what's called pre-atrial fibrillation, which is what we call as AHREs, or atrial high rate episodes, or there are extra beats that are coming in. Not every PAC will cause atrial fibrillation, but eventually with time it will. And then we have atrial fibrillation, that is paroxysmal, less than 7 days, persistent, that's more than 7 days, and long-standing persistent, more than 12 months. And these days, because we are so aggressive with the management and successful, we have successful AFib ablation category as well, because we essentially changed the category of their atrial fibrillation or downgraded from one to the other. And then permanent meaning that the physician and the patient have decided that we're not going to follow the rhythm control strategy any further. And then we need to treat the modifiable risk factors all along, whether they have AFib or not, and then heightened surveillance if they are in the atrial fibrillation group. So the pillars of management is something, it's a new concept that was put in the new guidelines, which says that there should be access to everybody, there should be shared decision-making, and we should be aggressive in treating the risk factors and behavioral changes. And the acronym they came up with is head to toe, and that is starting with the heart failure, exercise, hypertension, and diabetes for the head, and tobacco, obesity, ethanol, and sleep for the toes. We need to take care of the stroke risk for every single patient. We need to optimize their risk factors, which is these, and then symptom management, which is either rate control or rhythm control, depending on where we are in the disease process. If you see at the bottom, no matter what you do, no matter how aggressive you are with the medical therapy or with the ablation therapy, if you do not control the basis of why they have atrial fibrillation, the risk factors why they are going in atrial fibrillation, none of what we do is going to be successful. So the focus should be on managing the risk factors very, very aggressively. And we're going to talk about what needs to be done from our standpoint as physicians to control these risk factors, which is the first thing is age, which we can't do anything about, but understand that an age increase of 5 increases the hazards of roughly by 1.5. Smoking increases the risk factor, like we all know. Physical activity, if you have a sedentary lifestyle, there's a 2.5 odds ratio for the risk of atrial fibrillation. But interestingly enough, if you are an elite athlete, your risk of having atrial fibrillation is about the same, which is what we've seen in a lot of medicine, that there's a U-shaped curve. Either whether you're sedentary or you are very active, you are going to have all these complications. So an optimal amount of exercise is what's required to prevent atrial fibrillation. And alcohol, we know that there is increased risk of atrial fibrillation whenever somebody drinks alcohol. The more you drink, the more the risk. And there was a randomized study where they reduced the risk of atrial fibrillation by abstinence. So it is a direct relationship. And actually the study done in 2021, published in Annals of Internal Medicine, so a very well-reputed study, even a single drink of alcohol increases the risk of atrial fibrillation by 2 times in the next 4 hours, which is where it peaks. And then it stays the high for about next 8 hours, and then it goes down. So the misconception that 1 drink of wine is fine is not valid. It's just a convenience that everybody wants. They can do whatever they want, but studies suggest that even a single drink of alcohol puts you at a 2 times higher risk of atrial fibrillation going forward. And we've seen patients where they have 1 drink and they go in atrial fibrillation. Then we have this weight or obesity. The cutoff is around 28 for BMI, and the more BMI we increase, the higher the chances of atrial fibrillation. And it also correlates into the management. If somebody's BMI is more than 28, and despite doing ablation therapy, the success of ablation goes down significantly if the BMI is more than 28. So weight loss is very important for reducing the burden of atrial fibrillation. There is an association with the height as well, and we know the higher the blood pressure, the worse the remodeling for the heart, including left atrium, which is for atrial fibrillation. And the goal is less than 120 millimeter of mercury for the blood pressure. There are some association with heart rates. It's more like keeping the heart rate within the regular ranges rather than having inappropriate sinus tachycardia or bradycardia, because that predisposes the heart with long short sequencing or other factors to be more liable to go into atrial fibrillation. And diabetes, we need a better AFib control. I've been talking about all these risk factors, the hypertension, the coronary disease, the obesity, alcohol, and sleep deprivation with different mechanisms eventually lead to increased atrial PAC or automaticity, leading to atrial fibrillation going forward. Now, taking a break, because I know with presentations we have to stop and reflect. So we talked about losing weight. So if you have somebody that's new onset atrial fibrillation, BMI of 37, how much weight loss do we think is going to be important? Because if they are BMI of 37, they're 265 pounds. Because sometimes people are like, we are way overweight, nothing's going to work, and this, regardless of what we do, which is not true, because only 10% of body weight loss is required, and that is based on studies where if you lose 10% of body weight, regardless of your weight, it is going to be the most beneficial for maintaining normal rhythm going forward, and that's a class 1 recommendation in the guidelines as well, and this is where the BMI of 28 comes from as well. In terms of the lifestyle modification, this is the same thing, the exercise. 210 minutes of exercise is recommended. That's like 30 minutes of exercise every day. Smoking cessation is recommended. Alcohol cessation is recommended. This is something that has been kind of ingrained into us from med school and medicine residency, which is probably the first thing that our attendings were like, forget about this because this is not true. There were multiple studies done, including population-based, where they looked at the effect of caffeine on atrial fibrillation, and there is no effect. So it's class 3, no benefit in caffeine cessation for alcohol. So usually when I'm talking to patients and I'm telling them alcohol cessation, so they hate me, and I'm like, I will bargain with caffeine, and you can drink all the caffeine you want. It will give you palpitations, but no AFib. The second thing is the sleep. We all worry about the sleep apnea. There is some role, there's some data out there, but it is not as convincing as the other data that we have for all the other risk factors. So it's a 2B indication to screen people for sleep apnea. If they have sleep apnea, then we definitely need to treat everyone that has sleep apnea. And hypertension control is less than 120. When somebody has atrial fibrillation for the first time and we are evaluating, then we do need to get an echocardiogram, the basic labs, the CBC, the CMP, and thyroid evaluation, because thyroid is, or hyperthyroid is the reversible cause of atrial fibrillation. So we need to evaluate that. Ischemic evaluation is of no benefit out of context. So if they need ischemic evaluation, you do ischemic evaluation. If they don't need it, it is not needed from the atrial fibrillation standpoint. Now pivoting to the second pillar, which is the stroke prevention. We've all known about this, the scoring systems. What guidelines talk about is that we need to assess their risk scores based on any of the scoring systems that are available, which are a few, but the most common one that everybody knows about and follows is the CHADVASC risk score, and we all do these on a daily basis. The things that I wanted to highlight, of course, the heart failure is, we've become a little better with the heart failure already, but the thing that as a general cardiology community we are lacking in is the vascular disease portion. So if somebody has prior myocardial infarction, angina, PCI, or bypass, vascular disease, so essentially any vascular problems, they get a risk score from this, which increases their risk of the stroke complications or cardioembolic complications going forward, which we typically underrepresent. And then there are additional risk factors that are not discussed in the CHADVASC score, which is the more burden you have, the more persistent symptoms, persistent AFib you have, the obesity, the hypertrophic cardiomyopathy, the hypertension, the kidney function, and enlarged left atrial volume. These are all high risks for stroke. So if you have a stroke risk more than 2%, you should be on anticoagulation, which is roughly CHADVASC score of more than 2 for men and 3 for women. And then anticoagulation is reasonable between 1 and 2, which is CHA2DS2-VASc score of 1. And DOACs are actually preferred in the current guidelines over the warfarin because of the safety and efficacy, except if you have mechanical heart valve or mitral stenosis. Aspirin does not work. If anybody puts patients on aspirin because they have a CHA2DS2-VASc score of 1, it is not for the patient. And then it is no benefit at all for preventing. So this is exactly the same thing that we talked about, more than 2% where we need to do something about. The DOACs are recommended, and if that's intermediate risk, we need to have a shared decision making, and still it is beneficial to be on stroke prevention, and no benefit with aspirin. This is something that is newer in the guidelines, that if you suspect systemic thromboembolic event without any diagnosis, to increase the sensitivity of AFib detection, implantable cardiac monitors like the loop recorders are reasonable to be implanted in those patients. And with obesity, DOACs are reasonable over Coumadin as well. And if somebody's had a bariatric surgery, which is becoming quite frequent, that's why they addressed it, it might be reasonable to pursue warfarin because of the absorption issues with the DOACs. So now, coming to the treatment of the atrial fibrillation, the first thing that we all do for every single patient is cardioversion. And anytime cardioversion is done, they need to be anticoagulated for 3 weeks before and 4 weeks after. And this is something that we need to address and understand, whether you cardiovert somebody with pharmacological cardioversion or electrical cardioversion. It is the same. There is no point in thinking that electrical cardioversion is different than chemical cardioversion. Cardioversion is cardioversion. It acts on the heart the same way. The electromechanical dissociation is the same, whether you convert somebody with electrical energy or with chemicals. The guidelines suggest 3 weeks before and 4 weeks after is what's recommended. If somebody has a left atrial appendage occlusion, it's reasonable to do a TEE prior to make sure that the left atrial appendage is occluded, and that there is no leaks around and no device-related thrombus on the Watchman either. How much AFib is AFib? That is always a question that we get asked. And there were multiple studies done for this, and in the guidelines, they summarized by saying that if you have 5 to 24 minutes and the risk is high, it is reasonable to anticoagulate. But if you have more than 24 hours, then even with a lower CHA2DS2-VASc score, you should anticoagulate. And this comes down as a flow sheet where if the risk factors are more on the x-axis and on the y-axis, the burden. So if you're more than 24 hours and a higher risk, you definitely should treat that as atrial fibrillation. If you have low risk and the burden is low, then you just continue to monitor them, and everything else essentially falls into shared decision-making with the patient and understanding what their goals of care are. And these all came from like the Accreditation study, that if your CHA2DS2-VASc score is more than 4, the stroke risk is high. So if you have episodes more than 6 minutes, but not more than 24 hours, you can safely observe patients, kind of weigh the risks and benefits if the CHA2DS2-VASc score is less than 4. And then with the ASSERT sub-study, they subcategorized based on timing, which is more than 24 hours is the patient that are at the highest risk of thromboembolic events and should be treated as atrial fibrillation regardless. What do we do when somebody has atrial fibrillation? We all have been doing it. If they are not stable, we cardiovert them. If they are stable but decompensated heart failure or not, if anybody is decompensated heart failure, we try not to do any AV nodal blocking agents. Initially go with amiodarone. It should not be used indiscriminately for hemodynamically stable patients, which is what we see a lot of the times. Amiodarone is reserved, and that too with a class 2B indication, because we're putting patient at a higher risk. if they're not anticoagulated for stroke, because this is chemical cardioversion. And then if they are not decompensated, we do beta blockers and digoxin first before going to amiodarone for rate control. And addition of magnesium for AV nodal blocking agent actually is better because it augments the functioning of all the other AV nodal blocking agents. Rate control wise, we know if the EF is less than 40%, we shouldn't be doing calcium channel blockers. Everybody else gets beta blockers and then digoxin for rate control. Dronadrone is not a medication for rate control, which I don't know why they studied for rate control. Now, the AFFIRM trial was done in the year 2000, and fortunately we don't live in year 2000 anymore. There were a lot of things that were not available in the year 2000. So rate control is not equal to rhythm control anymore since 15 years now. There are factors that go one way or the other that push us to decide whether we need to do rate control or rhythm control, and these are patient-related factors. If somebody has a large left atrium, or less LV dysfunction, or less regurgitation and easily controlled heart rates, sure, and they don't want to be aggressive, we can do rate control. But everybody else, if there is a reason, we should proceed with rhythm control strategy. And that comes out as CHF. The more dysfunction they have, the more rhythm control or more aggressive we should be. The more symptoms they have, if we want to reduce the burden of AFib, then we should be proceeding with a rhythm control strategy. And even if they just have congestive heart failure without LV dysfunction, is an indication for rhythm control strategy. And if you want to prevent the progression of the disease, which will happen invariably in every single patient, then we should be focusing on rhythm control strategy as well. These are all class 1 or 2A indications, which is we should be doing them, and there should be a good reason why not to do them. And of course, then in uncertain patients and preventing dementia is a 2B indication for rhythm control strategy. So this is a slide that I kind of boggled about because I see a lot of medication given that I don't agree with, which is atrial fibrillation and abnormal function. The medication option is limitless. Whatever we have can be used: difetilide, dronadrone, flecainide, or propafenone, all with a 2A indication, and then followed by amiodarone. And if they have LV dysfunction, you do amiodarone on difetilide, and then questionably can consider sotalol because of the same LV dysfunction. And guess what's at the bottom? It's sotalol, because it is the least effective medication for rhythm control. Unfortunately, nationwide, it is the most commonly used medication for rhythm control. And it should only be sorted out before harm. So it should be thought of in the same way, that this only is valid, or it's like the last string that you're drawing to see if we can do something. Everything else has a better indication and should be used that way. And if somebody has congestive heart failure, we don't use dronadrone. And we're going to talk about this heart failure separately if we want to decrease burden of atrial fibrillation. Always, we have to do shared decision making. If you saw, all the indications were 2A indications for all the medications. The only class 1 indications for management of atrial fibrillation are catheter ablation for select patients, and we're going to talk about which patients, or if the antiarrhythmic medications are not effective. Everything else is a 2A, 2B indication. So if somebody has heart failure and you've done everything, you need to do everything from the heart failure standpoint, and then cardioversion, if it's indicated, is a class 1 electrical cardioversion. It is preferred to do electrical cardioversion because it's more effective, more safe, more quick. Chemical cardioversion or pharmacological cardioversion can be done, but it's slow, takes time, and of course affects the heart with the medications that prolong the QT interval. So we prefer not to do it unless we don't want to put them under procedure or sedation. For rate control, we talked about the beta blockers, the digoxins, the amiodarone, and then we're going to talk about all these lines in the next slide, which is we evaluate the patient for rhythm control strategy with a catheter ablation. If they're a good candidate, which means they're going to benefit because they're earlier stage of heart failure, they have no significant scar, there is no or mild fibrosis, they're paroxysmal or early persistent, or younger patients. For heart failure with reduced ejection fraction, it's a class 1 indication to proceed with ablation. Anytime a patient has heart failure with reduced ejection fraction and atrial fibrillation, they should get an ablation, or we should document why not, because it's a class 1 indication, standard of care. If they have preserved ejection fraction, then it's a 2B indication. And then otherwise we have if they're not likely to benefit, then we have pharmacological management, and if need be, we can do a pace and ablate strategy as a 2B indication. That's all at the end, but not as the primary treatment. And all of this comes from multiple trials over the years that have shown, like the ATTACK trial, catheter ablation significantly beneficial than the most efficacious drug that we have in freedom from ATAF. Cabana trial, of course, we have all talked about in the grand rounds and the journal clubs, but there is freedom from recurrence that is consistently better along every single trial. Castle AF, freedom from hospitalizations. And the thing that changed everything and made sure that the guidelines get that first line or class 1 indication was the East AF net, where rhythm control versus usual care, and the trial had to be stopped early for overwhelming benefit, was the East AF net trial that even if you do early rhythm control for asymptomatic patients, they are going to separate out pretty soon before the 2 years, so about 1 year into randomization. And then it just keeps on spreading out as time goes by. There was another trial that recently came out, the Castle HTX for advanced heart failure patients, and that's where the class 1 indication comes in, because the worse the LV function, the better the effect or benefit from the ablation therapy. Then we had these 2 trials, the STOP AF trial where we did ablation as the first line therapy instead of the drug therapy, and it was better. Course, and early AF, which was also done by cryoablation or drug therapy as the initial therapy for AFib, and that is better. Of course, the numbers are not perfect. Ablation is not 100% cure, but this is the best we have at this time for maintaining normal rhythm. So previously, all these trials were done with thermal energy or heat energy, which was either RF, so we cauterize these areas around the pulmonary veins because that's the trigger, so we isolate the veins electrically, but there was a risk of damaging the phrenic nerve or the esophagus that lives just behind the left atrium, or with the cryoballoon, which is where the trials were done for the first, and they're both equal with the fire and ice trial, that the RF and cryo are the same, but they both have the same collateral damage as well. Till we came up with PFA about 2 years ago now, where we create an electrical field and it is cardioselective. There is no permanent damage to the phrenic nerve or esophagus that has been seen in all the patients that were done. The atrial arrhythmia burden, less than 1% was higher. What that means is that the burden more than 0.1% is lower in PFA patients compared to the thermal ablation group. So this is more efficacious, and this is much safer for the patients as well, with the energy-specific complications being less than 0.1%. Otherwise, these are just the risks of getting into somebody's heart, where there is always that 1% chance of major complications and 2% chance of vascular minor complications at the access site. So to finish it off, we should always address reversible risk factors. DOACs are preferred. Trial of rhythm control should be considered for many, if not most patients, particularly if they have symptomatic AFib, or if we want to reduce stroke, prevent remodeling, reduce risk of CHF and dementia, and early catheter ablation should be considered. Any questions?
Thank you so much.
Thanks so much for that really enlightening discussion. I think that was really well done and highlighted a lot of the more common changes made recently. And hopefully this will inform our practice as we go forward. Having said that, we're going to open it up to the audience to see if there's any questions.
Just raise your hand if you have a question.
Oh, Dr. Ahmed. Oh, okay. No, sorry. Dr. Hahn.
Great talk, Murtaza. Very informative. Quick question, just giving you a scenario. What do you think about treatment of asymptomatic AFib? I mean, see, you got these patients that often come to the clinic that are in AFib but are pretty asymptomatic and rate controlled and they're doing fine. What's your approach to these patients?
So just like with the other, deciding whether you're going to go rate control versus the rhythm control, that one slide that we had, if their left atrial size is normal, and depend on whether they have heart failure symptoms or not, we know from advanced heart failure that once you have atrial fibrillation, on the risk scoring on the H2PF score, the heart failure with preserved ejection fraction risk goes significantly high with atrial fibrillation. If they're young, I think being more aggressive with the rhythm control strategy, especially ablation, is reasonable, but the indication is not the same as class 1 or 2A. It is a 2B indication to proceed with ablation for those. And maintaining normal rhythm, we know it's going to prevent the progression of the disease. There's a common saying, AFib begets AFib, and that is driven out of a study where they left patients in different time frames of atrial fibrillation, which was 2 hours, 4 hours, or 24 hours, prior to taking them to the EP lab for procedures and then trying to induce AFib. So the longer you stay in atrial fibrillation, the more difficult it was. So the longer you are in the atrial fibrillation, the easier it was to induce AFib in that study. So that's why it makes it hard to maintain normal rhythm going forward. They are fine now, we're completely asymptomatic, but the risk of heart failure is significantly elevated. And once they develop atrial fibrillation, then you're going to be doing rhythm control strategy, but then at that time you have lost a lot of time where you could have been very effective in maintaining normal rhythm.
Thanks, Murtaza. Really, really good talk. Great job, condensing a really big, complex topic, and even like an interventionist like me could understand that. So thanks. One of the questions that often comes up is the role of anticoagulation after a successful ablation. So what would you say, now that our ablation technologies have improved, they're more predictable, what is the current best practice for that?
So that's a very good question. I think there's no simple answer because there's no guidelines about it. There were multiple trials that were done previously that showed that even after successful ablation, we should not stop the anticoagulation because of the same risk that if there is more atrial fibrillation, it will be a risk of stroke. However, there was a recent trial, I think in the European Heart Rhythm Society that came out that showed that if you have no AFib after an ablation, it might be reasonable. So it is still work in progress. There's no official consensus. As a general rule, we will not stop anticoagulation based on the successful ablation unless we have a permanent way of monitoring for atrial fibrillation that is objective, that either they have a device or have a loop recorder where we will be notified if they have atrial fibrillation. And that too is not guideline directed. It's more of a patient preference. They don't want to be on blood thinner. So currently there is no recommendation on stopping the blood thinner.
If I can, let me ask one quick question. So what about patients with left atrial, I think you touched on this a little bit, left atrial appendage closure devices? If you end up cardioverting those patients, or what, should we anticoagulate or not anticoagulate? I know that's been a topic of discussion recently.
Yeah, we were having the same discussion in our EP section meeting like 2 weeks ago. And it's the same thing, there's no consensus. There are two forms of data that have come out for this particular topic because it's the new emerging topic. The European data they don't do anything and they're fine. There are some strokes, they're okay with it. In the US data, we should be doing TEE for everybody, plus minus anticoagulation. So if, depending on on the realm of how safe or how aggressive you want to be, the safest thing to do is do a TEE and anticoagulate for 4 weeks. The most aggressive way of not doing anything is do nothing, just cardiovert and hope nothing happens. Or we can come up with something in the middle where we at least do a TEE to make sure there is no device-related thrombus. At KU, we did a lot of studies. We came up with the risk scores for DRTs as well because we were the big Watchman program or left atrial appendage occlusion program. There are late DRT complications. It's not that within the 45 days it will happen. We did see about 2% risk of DRTs that was late, which is 1 year after the Watchman was implanted. So I don't think there is any way or reason we should do a cardioversion without a TEE. And then anticoagulation is up to as to why the Watchman was done, how bad the bleeding complications are. If it is safe to give anticoagulation, it would be the most safest way.
Do we have any questions online?
Yes, we do. We do have about 3 or 4 questions that came through online. First question, what is the guideline on need for anticoagulation on those who undergo, hold on, just had a pop-up, who undergo surgical appendage closure?
So that's
Hopefully there are no surgeons listening as you answer this question.
So we brought this up to our surgical team, and it's not just here, it's everywhere, because the studies that were done for the surgical appendage ligation did not stop blood thinners. So none of the studies that were done, they stopped anticoagulation post-procedure. So the inference that we're drawing from the study is that we should not stop blood thinners, but we know that it's safe. It's effective, and it reduces the risk of thromboembolic complications. But in the real life, which is another, after any trial, when we start doing new procedures, we have real life experience. The real life experience that has been published after these surgical ligations show that there's a lot of anticoagulants that have been stopped. So far, that is off the guidelines. It's more physician preference. Sometimes it's just that, oh, I've closed it off. It should be good. Should be is the key word. Unless we do a TEE and make sure that the surgical appendage ligation was done the right way, it was completely occluded, there is no lobe that's left, and even then, it's gonna be a shared decision-making between the patient and the physician to come off the blood thinner safely, understanding that it was not done in the trials, but it has been done in the clinical practice since.
Yeah, I mean, I think there's even data to show that up to 30% of these within, or even more, within 12 months are still open.
Yes, so we have to do a TEE. There's no way we should just stop anticoagulations. If anything, if for whatever reason we need to, there needs to be a TEE or a CT that documents that it is completely occluded. And even then, it's more of a expert opinion, physician preference, patient preference, rather than guideline directed.
Thank you. And Dr. Gersh also has a question online. What are your thoughts on surgical convergent maze for persistent AFib?
So previously, we had very consistent data with the CONVERGE trial that if somebody has longstanding persistent atrial fibrillation, the endocardial thermal ablations that we did were not as effective, with the success close to 50%. The only beneficial way to take care of them was surgical convergent procedures, where we do surgical epicardial ablation first, followed by an endocardial ablation for those patients. And it is a well-known treatment, and it works. In the recent time frame, with the pulse field ablation coming in, we know that we get more effective lesions, and the role of convergent procedures is going down, but it still has a role in long-standing persistent. But I think that's where the discussion is, because most of the patients that we see, the patients have been in long-standing persistent atrial fibrillation for so long that their left atrial volume has dilated so much that sometimes it's not even a point attempting rhythm control. So if we see somebody going into from early persistent to late persistent, we will be more aggressive with the ablation therapy. If it doesn't work, then we will do surgical ablation.
Okay, thank you. Dr. Scully also has a question online. As a reminder to those who are viewing online, if you're raising your hand, please put your question in the chat. We won't be able to unmute you during the program. I'm sorry, the Q&A, not the chat. Okay, Dr. Scully's question is, if the patient has LAAO device, do they need AC prescription prior to repeat DCCV for recurrent AF?
Yeah, this is what we just discussed, and it is more of, like I said, physician preference. The place where I was trained, KU, where we've done maybe 2,500 left atrial appendage occlusions over the course of last 5 years. Our protocol was that we would tell the patients when we're doing left atrial appendage occlusion that this is going to take away the need for anticoagulant, but you may still need intermittent anticoagulant, which was around the time of cardioversion. So we personally would do it, and I know there are other places where I work, very big names in EP that do not. So it's all based on that the sequence of how safe you want to be and how much risk of bleeding there is. If somebody's going to bleed with a single dose of anticoagulant, better not anticoagulate.
Thank you. And Dr. Kumar has a question. When should I anticoagulate a septic patient with atrial fibrillation without history of atrial fibrillation in the past?
So that's something that is also one of those very good questions, by the way. These are all things that we, as EPs, are concerned and questioned about ourselves. But this is one of those topics where there are two schools of thought in EP. One of them is because of one study published in JAMA, which was secondary AFib. If you have a severely sick patient with secondary AFib, and then it reverts back. Same goes for surgical AFib as well, that you have as AFib post cardiac surgery, and then nothing happens afterwards. And there's one school of thought that says that it was secondary. And if you have no documented atrial fibrillation in the regular or normal life, then there's no indication. And the second group of thought, physicians or EPs think that once you have AFib, you've shown that there are triggers, their substrate is enough that it's going to cause recurrence of atrial fibrillation, and we should just treat it as atrial fibrillation. However, it has to be adjudicated with the patient's risk factors, what their CHAD-VASc score is. If their score is 2, just as with all the other ASSERT and the Atresia trial, we can wait safely with the event monitors, ILRs, till we have a true documented atrial fibrillation episode. But if somebody has a higher risk score, then we need to be a little more worried about those patients and not just blow it off as secondary AFib.
Yes, thank you, Dr. Sundhu. I just have a question, a practical one when it comes to patients with atrial fibrillation and heart failure. You did say the ablation is the class 1 indication, but what would, because here a lot of times we do tell patients that, oh, these ablations are outpatient procedures. So what would be the reason to do it inpatient? Because a lot of times when they're here, they're stable and they say they want to do it here. I don't have an explanation as to why they need to go home and come back.
So that's a very good question. It's more about how we do things in medicine. All the trials that were done, they are not inpatient ablations. These are all outpatient ablations. What that means is that even in the East AFNet, the time frame was less than 1 year, not the same hospitalization. I know when we see patients, we want to make them better as soon as we can, but there is a way to do things. If we start with more procedures, more ablations, that comes at a cost. We do inpatient ablations. At KU, we used to do roughly 1 or 2 AFib ablations inpatient a week. But that was because we would get all the sick patients, all the advanced heart failures, and there's no way for us to control the rates. Previously, before the PFA came along, we would do pace and ablate for cardiogenic shock patients with unable to control heart rates. But now, if we're unable to control heart rates, that we cannot manage their atrial fibrillation with medication in advanced heart failure, it is reasonable to proceed with inpatient AFib ablation. The inpatient AFib ablation is supposed to be considered as only as the backup, the last resort, where you cannot manage their atrial fibrillation with other things. Anytime you do ablation, there are risks, minor groin complications. If somebody's already in advanced heart failure, you don't want to put extra risks on them till they're feeling better or doing better. But we will not shy away from doing an ablation if the patient truly needs it, which is unable to manage the atrial fibrillation as inpatient because of how advanced the heart failure is. So the two options for inpatient is either pace and ablate with a CRT device or inpatient ablation these days, which I think is better.
Thank you so much, Dr. Sundhu. I have a question just going back to the topic of electrical and pharmacologic cardioversion. So I think a lot of times we find ourselves in situations where the patient is not technically hemodynamically unstable, but they're not decompensated heart failure, but their blood pressure is a little bit soft. And we kind of put on IV amiodarone. In those situations, would you say in the first 6 to 12 hours of use, we're able to kind of lean on the beta blocking effects for rate control with the amiodarone, or do we still need to be concerned about pharmacological cardioversion in that time period as well?
So I think just from like the organization perspective and understanding perspective as well, that's a very good question, first of all. It means that you've been managing these patients and are thinking about these things, which is very good. So if you think using AV nodal blocking agents and the blood pressure is borderline, not bad enough for you to cardiovert, but not good enough for you to give the medications, the 2A indication is digoxin. So that needs to be given first for rate control, if you're thinking of rate control. And then secondly, if you want to do amiodarone, then it shouldn't be just the protocol order set that comes in. The higher the dose of amiodarone, the more the chemical cardioversion risk factor involved with that. If you want to do the rate control, you can put in at a lower dose, never give a bolus, and start with the 0.5 dose and just use that as rate control, but document why you're using it because of inability to use other medication and using it as rate control at a lower dose. If you just put in an order set and like, let's just put it in because that's what Epic tells us to do, that is not the right way. I've stopped more amiodarone here to get TEE first than otherwise.
I was going to add to that because I think what Courtney was getting at was pharmacologically, the whole notion is that for amiodarone to have the antiarrhythmic effect,
it is 6 to 8 hours.
Exactly. You need a good loading dose versus in the acute setting, the thought is that you initially get more of the beta blocker effect. And if the patient converts, then some may term that as a spontaneous conversion rather than a chemical conversion.
And that's true. Like, for example, when we see a lot of patients, they get started on the cardizem or diltiazem
Correct.
infusion, and they're like, oh, they started me on a medication that converted me to normal rhythm, which is the same as spontaneous conversion. However, there is no way for us to know, no studies that were ever done, that it does not work in the first 6 hours. And then at that time, we're liable for any cardioembolic complications that happens.
I think to that point too, I mean, ultimately, if the patient is critically ill, I mean,
For sure.
all
Critically
bets
ill
are off.
trumps everything.
You just take care of the patient and,
Exactly.
worry about the anticoagulation as you go along.
Hi, I had a quick question for
Just do a
you.
quick intro. Sorry, I didn't mention that earlier. So. Quick introduction of who you are. Yeah.
Hey, I'm Christine Cyclo. I'm one of the cardiology fellows. Dr. Sundhu, thank you so much for your talk. I was curious, what are your thoughts on monitoring AFib at home with things like the Apple Watch or Cardia device, especially for those patients who have baseline bradycardia, don't want to be on medications, and believe they had something like secondary AFib?
So that's also very good, and it ties into the world that we live in now. Of course, it has to be used appropriately, and you know how the burden of all these strips on the physicians is getting alarming at times. But having said all this, these devices are very good and they do work, and these are FDA approved as well for monitoring of atrial fibrillation. When I see a patient with atrial fibrillation, I actually ask every single patient, what is your way for monitoring atrial fibrillation? Which is how we used to do things in my training, which is either they need to check their blood pressure with the cuff that tells them they're in atrial fibrillation, or they have an Apple Watch or a Samsung Watch or a Fitbit that does have atrial fibrillation monitoring. The Apple Watches have an AFib burden algorithm as well, which has been adjudicated, and then the cardiomobile devices as well, where they need to check their rhythm every day or so. And those are very reasonable. They work, and they should. I actually encourage every patient to get them.
Hi, Dr. Sundhu. Vikas Kalar, one of the cardiology fellows. Thank you for the talk. I was wondering about, I've seen some data or trials on high dose or continuous magnesium infusion as an adjunct for rate control in AFib. Do you ever consider this or any role for this, or is this kind of fallen out of favor?
So even in the
I did see
guidelines,
a brief slide there, yeah.
there was, like when we talked about rate control, there is adding magnesium to the rate control. So it's a 2A indication. So we should be adding magnesium to rate control medication.
Do you think there's a reason that we rarely do this?
It's more about same thing as how aggressive we are with ablation with all these patients. It's gonna come with time. I think this was the first time it was incorporated in a guideline document, and eventually people will catch up and start doing this. Like somebody comes in, give them IV magnesium, and then start AV nodal blocking agents.
Thanks.
Okay, we do have one more question online and a comment. And we do have time to take this last question.
Suzanne, we had
Two questions.
one up
Okay.
front too.
Okay, Dr. Rajay is asking, most effective rate control medication in your opinion? And additionally, BB versus CCB in stable patients without clinical heart failure. Any data, one better than the other?
So actually, I specifically was trying to read if one was better than the other. They actually comment on this in the guideline document as well, but there is no one better than the other. There was something when I was in medicine residency that we had a saying that, of course, the calcium channel blockers work for most patients, but for whatever reason, for alcohol-driven AFib, again, there's no data behind it. It was one of our clinical clinic residency things that you know how it's famous in the ICUs. The beta blockers work better for the alcohol-mediated, probably to suppress all the other beta-energic activity, to control the rates better. As we all know, flutters are very poorly rate controlled, so anything that works, if the EF is better, maybe start with calcium channel blockers. Some supposedly better titration than beta blockers, or easy titration, I should say. And then if the EF is worse, then beta blockers. Okay. But there's no head to like one better than the other.
Okay, thank you for that. And then last question from Dr. Kumar. Is the risk of stroke different if patient spontaneously converts versus converts from beta blockers versus conversion from amiodarone?
Yeah, so the risk is definitely different, and spontaneous conversion is spontaneous conversion. The way we look at it is that the left atrium is in atrial fibrillation, so all parts of the left atrium are fibrillating, and then those fibrillatory activities stop, which is that the left atrial appendage that's on the side is fibrillating, and then it stops, and then the normal rhythm comes through. So it should start contracting if it is converted spontaneously, which is with or without beta blocker activity. If we do electrical cardioversion or chemical cardioversion, cardioversion is the word. It's us that we have categorized it in two separate forms. When we do cardioversion, there is something called as electromechanical dissociation. What that means is that we stun the way the cardioversion works is that we depolarize all of the left atrium at the same time, either with the electrical energy or suppress the electrical activity in all of the atrium enough that it is unable to perpetuate atrial fibrillation. What that does is that it dissociates the electrical activity with the mechanical activity of the appendage. And even though the sinus rhythm comes through, the appendage does not contract. And there were multiple studies that were done along the years. Most of the appendages actually recover after 2 weeks. 95% of them recover after 3 weeks, but 100% of them recover after 4 weeks. And that's where the recommendation for 4 weeks of anticoagulation comes from, that we know that after 4 weeks, essentially all of the left atrial appendages start to contract. There are some patients out there where the appendages do not actually undergo electromechanical dissociation, but that we cannot make that judgment based on nothing. Either we need to put a TE down and see what their velocities are, which is very not feasible, and otherwise there is a difference.
One question, Edwin had a question. While she's getting to that, could you quickly talk about one or two groups of patients where the CHADS vascular doesn't apply, CM, amyloid, and so on?
So
what where they automatically get anticoagulated.
So that's what Dr. Eglum is pointing out to, that there are certain risk of groups of patients that are very high risk, like the amyloid, the HCM patients that are not accounted for in the CHAD-VAS score. And the reason is that once you have atrial fibrillation in those patients, you need to be anticoagulated. And the reason is just the substrate itself is such that other risk factors, even in the absence of other risk factors, the risk is high enough for them to be anticoagulated.
Thank you very much for the presentation, Dr. Sundhu. My name is Edwin, one of the CARDS fellows. I actually had two questions. The first is, you mentioned something about atrial electromechanical delay. I was thinking, this is more of a forward-thinking question. Do you think that there's any sort of role in use of echocardiography to maybe predict the onset of future atrial fibrillation in patients? Because it's been noted in patients, say, with Duchenne's and Becker's muscular dystrophy, you do see that there is some atrial electromechanical delay when you look at the onset of the QRS complex or the P wave and also the tissue Doppler. So do you think that, forward thinking, do you think that there's any role of using echo to maybe predict future atrial fibrillation? And the second question is, we know that the blanking period is about 6 months, and I think 3 months. 3 months, and this is for usually thermal ablation. Do you think that this period is going to be less now that we use PFA? Thank you.
Okay. So the first question, so far there's no studies suggesting the role of echocardiography in suggesting one way or the other. The thing that we know from echocardiography is that if your left atrium is dilated, of course you're going to have more atrial fibrillation. There's no way for us to know scarring. You may have a dilated left atrium with no significant scar. The only way to figure out scar is that going endocardially and mapping the left atrium, which is what we do for every ablation procedure. And then we target ablation based on what we see, other than the pulmonary veins, like other triggers, and how far along they are in the disease. Like we were seeing initially that the substrate that maintains atrial fibrillation is significantly more. So that's the only way. The second question about the blanking period, that's an ongoing debate in the EP community. We are trying to figure that out because we've done 3 months historically. Same goes for anticoagulation. And for the same reason, the concomitant procedures, we do 3 months of anticoagulation afterwards for ablation, not for the Watchman. Or left atrial appendage occlusion component of the procedure. And the reason for that has been the thermal ablation, disruption of the endocardium, and more risk of thrombogenesis. But this is up for debate because now we have a non-disrupting form of energy. The blanking itself might not change, in my opinion, because it's still the same thing that we want to give it some time. And it might change to 1 month, which is one of the recommendations that's flowing around. And same goes for anticoagulation. That in the absence, if the CHAD-VAS score is 0, you do ablation, and then how long you need to be anticoagulated for the ablation itself is going to be probably reduced in the next 5 years, but it's still up for debate.
All right, well, thanks everyone for coming out, and thanks again for an enlightening lecture.